Welcome to the Beverly Hills Plastic Surgery Podcast. I'm Dr. Jay Calvert. I am here today with my very amazing and esteemed co-host, Dr. Millicent Revello. How are you?
I'm doing well. How are you?
I'm feeling pretty good. I'm pretty excited about this new podcast format.
Yes, we are branching out. We no longer have faces for podcasts. We are now putting ourselves out there visually.
But we didn't call hair and makeup for this. We're winging it on that thing.
We're winging it. Fresh off a day of seeing patients and operating.
You can see like the very fancy outfits we've put together, and we're ready for the whole TV, YouTube streaming thing.
This is why we did podcasts previously, but we are branching out to a video format.
I think it's good because plastic surgery is a visual specialty.
By definition.
Yeah, so we need to show photos and videos and all that stuff, so that's what we're going to do. So today I want to jump right into it, and I want to talk about breast augmentation in a much more visual sense.
Right. Breast augmentation or breast implants, one of the bread and butter procedures that we do. It's one of the most common, if not the most common, plastic surgery procedure done in the United States. So it's important that we have a very real, honest, educational discussion about what exactly breast augmentation is about.
Right, it's a pretty straightforward procedure where a woman or man becoming a woman or whoever wants to have larger breasts. It's pretty straightforward.
It is, but it isn't.
No.
I mean, there is a certain group of patients where you can put a pair of implants in and that patient looks great. But I would say that's like 15, at most 20% of patients.
Totally.
It's not just a breast aug. Every patient needs a little bit more finesse. You know, like if you really want these to look good, you do have to put in a little bit of effort. I don't think you can just say it's just a breast aug.
Right, so it is an artistic endeavor.
Definitely.
I know that people think of it as a very simple procedure, but I am in full agreement with you that there is a very significant amount of artistry and planning that goes into generating a great result with a breast augmentation.
I couldn't agree more. And breasts come in all different sizes and shapes, and desired outcomes are all different sizes and shapes. And it's not always as simple as it sounds to just throw an implant in there.
No. I do want to note that we both agreed with each other 3 times over. So if we're keeping score, we want to have that on the scoreboard.
Good.
So who is a candidate, Dr. Revello, for breast augmentation? Is it somebody who's just a woman with small breasts, or are there women that have some breast tissue? Who's really the candidate for breast augmentation?
I think as long as you are healthy and able to undergo surgery, you are a candidate for breast implants. Small caveat, you should be of a certain age. The breast implants, the silicone breast implants, are actually approved in women over age 22, saline in women over age 18. Those are kind of nitpicky things. Those are not hard and fast rules per se. But ideally, your breasts have stopped growing, you've reached maturation of your breast tissue, and you've decided that you are ready physically and emotionally, mentally, to have a breast augmentation. And then the upper age limit, 80 years old. If you're healthy and you want bigger breasts, come on in.
That's right.
There's no limit. The only thing that really changes is whether or not you need a lift along with the implant. And that's a whole different topic. But as long as you are healthy and physically able to undergo surgery and you want larger breasts, you're a candidate.
Yeah, and the goal really is to have better looking, larger breasts.
Yes.
Now, some patients just want to fill out what they used to have, especially in the postpartum woman who has lost breast tissue from postpartum involution, which means after having a baby, and you don't necessarily have to have breastfed, the breast tissue tends to shrink.
It does. Ironically, it gets bigger, and then after you've had the baby and you've lost the weight, you actually lose breast tissue in addition to the skin itself becoming a little bit more inelastic and droopy. You actually lose breast tissue as well. So there is a subset of women who may not necessarily want to be bigger, and maybe they don't exactly have enough skin or need a lift, but they just want to be a little more filled out back to what they used to be. Then a small breast implant is a great option for those patients as well.
What about fat grafting with breast implants? Is that something that you like to do?
I do. and that can be a whole separate topic as well.
That's a whole other podcast.
But yes, I do love fat grafting with breast implants. I think you can use it for a variety of reasons, whether to camouflage hard lines, provide more softness, allow for a smaller implant, more natural breast look. Women that have a really wide sternum and their implants are going to sit wide on their chest, I think putting a little fat in the middle is a good way to sort of bring them in closer, get more cleavage. So there's a huge variety of reasons why you could also do fat grafting with implants.
Silicone or saline?
Silicone, like hands down. I don't know if we're voting on this one. I vote silicone.
Well, we got a few behind us here, and I'm just and just for our listening audience, we have a bunch of silicone gel implants around, and for those of you watching on YouTube, this is sort of a standard silicone gel, high-profile implant.
What is this?
I don't know.
This is a super high-profile implant, actually by Allergan. This is a 545cc implant, and I think on our next podcast we're going to go through the different styles of implants and the different choices. But the most basic of choices is saline or silicone. Saline is sort of, if you think about a water balloon.
Yes.
The outer coating is silicone. You're not getting away from silicone in your body, but the inside is saline or salt water, as opposed to a silicone implant, which has a silicone outer shell, but on the inside, it's filled with a silicone gel.
Right, and today, the silicone gel implants are cohesive gels, so that they don't, when they rupture, if they do rupture, which I haven't seen a rupture in, I don't even know how many years since these new devices have come out, but the gel inside is cohesive, so it won't spill out and go all over the place. Like the old silicone gel implants were very liquidy silicone. They were not cohesive.
Right, and there's different.
In fact, they were called low bleed. Do you remember that?
No.
So low bleed meant that there was a bit of silicone outside of the gel shell because it would pass through because they were so close in nature. This is not going to happen with this. This is a unit of silicone gel, and then it is coated with the outer shell.
Yeah, it's not going anywhere. And there's different levels of cohesivity, but the idea is that, it's not a liquid. If it leaks or if it ruptures, it's not going to leak everywhere. It's going to stay more or less intact.
What's the over and under on how many times we slap that implant during this podcast? I just want to know, because it's like you can't help yourself. It's like they're just, they're like stress reliever balls.
They are.
They really are. Like if you're in traffic, like that's a great thing to have in the car.
Well, I noticed, I always show my patients the implants when we're having a breast augmentation consult. I let them feel it, let them play with it, and then I always find myself taking it back, and for the rest of the consult, I'm just like squishing it. I'm like, I'm sorry. I'm like in front of you just squishing this implant.
But they are. They're great devices. They're very tough. There are videos of them being run over by tractors and dropped off buildings, and they're very tough to break.
They're not going anywhere.
I prefer silicone also. I think they're better. There's a lot of controversy with breast implant illness and whether or not the implants make people sick, and there definitely was an issue with the textured implants in certain companies in the Allergan implants causing a very rare form of breast cancer, but caused it nonetheless. And so I've been removing the textured Allergan implants and in some cases replacing them, and in other cases women said, I'm done with them. Let's just put in a smooth, or just do fat grafting, and I'm finished with implants.
And I mean, that very rare cancer, ALCL, it's been seen in all manufacturers. It's just Allergan had the highest number, so those were the ones that were recalled. But those are the textured devices. I don't use textured devices.
I never have.
I only use smooth. If you think about the difference, a textured device sort of has like a Velcro-y almost type surface. It really sticks to the surrounding tissue, as opposed to a smooth implant, which is, as it sounds, smooth. So the reason I like silicone over saline, I think the silicone has a more natural, softer look and feel, both looking at it visually and actually manually feeling it. And because if these things rupture and saline implants rupture, that breast is gone. It's like popping a water balloon.
Yep.
That night you have it, that morning you don't, and that's an emergency.
Call your plastic surgeon.
Because you are now lopsided, you no longer have a breast on one side.
Yeah.
So as opposed to a silicone implant, if it were to rupture somehow, you wouldn't even know. Like, you wouldn't know, you wouldn't lose any volume, your breast would still look exactly the same. So that is my preference. I do have patients that still come in and for whatever reason want the saline, and that's fine. But if given my preference, I choose silicone.
How is the procedure done? What is your, favorite approach? Do you like, we have multiple ways that we can put in silicone implants. We can put them in through periareolar incisions, which is an incision around the pigmented part of the nipple areolar complex. We can use an inframammary approach. There's a transaxillary approach. What's your favorite approach to that?
It depends on the patient. If I'm doing a straightforward implant in a patient that doesn't need a lift and doesn't have any weird, not weird, but other breast abnormalities, straightforward breast implants, I choose the IMF approach, which is the crease under the breast. In most patients, it's very well hidden. You'll never see it again. It heals very well. It gives great access. So that's my approach. If I'm going to have to do a lift anyways, or if the patient has some kind of tuberous breast deformity, I may lean toward the periareolar approach around the areola. That's not my favorite for baseline breast augmentations. There's a little bit higher risk of capsular contracture, higher risk of breast implant infections. So IMF, that's my kind of go-to incision.
Yeah, I like the inframammary fold also, and it's interesting. Back east, when I trained in Pittsburgh, and also at Cornell when I was in Manhattan, the IMF inframammary fold was the way that breast implants were put in. And out in California, it's like totally opposite. It's like periareolar all day long here. And I guess it's because of bikinis, maybe. I don't know.
That's in my training, I saw mostly IMF. That's what I do. I think it's just a great, not easy, but straightforward approach, and it's well hidden. The only patients where I might start getting a little bit lean away from the IMF would be in a very thin, typically Asian patient. If you put an implant in those patients, sometimes their skin and their implants don't actually hang over enough to cover the IMF, and they're a little bit visible.
Yeah, so the IMF is not as well developed in some subsets of the big term Asian patients. I agree with you.
Yeah, so those do well with periareolars, but in general, it just depends on the breast and what else we need to do.
Yeah, Asian breast augmentation could be its own podcast
really
too, because it's really different. The anatomy is different. The tightness of the inframammary fold is different. And there are all these variations in different ethnicities, and as plastic surgeons, it's our job to understand that and to account for it and do something about it to get the best results possible.
Right.
What typically happens in an operation? So you make an inframammary incision, then you lift up the pectoralis major muscle, because I like to go under the muscle. Are you an under the muscle
I'm
gal?
under the muscle fan, so you can put the implants under the pectoralis muscle, or you can put it over the muscle. Probably 90% of the time, I'm going to put it under the muscle.
True.
The only times I put it over the muscle are in my tuberous breast patients, where I need to do some work with the breast tissue, and I really need that implant to push out those constriction bands. That's a whole other topic. But other than those patients...
Oh my God, tuberous breast is like
that is... You can do a whole fellowship in tuberous breast. But an otherwise not tuberous breast, congenital breast deformity patient, I will go under the muscle. And so typically you make that incision in the IMF. It's usually, about maybe centimeters, 4 to 6 centimeters in length. And then you go right down to the chest wall. You lift the pectoralis muscle up off of the chest wall. I typically take it off completely at its insertion all the way to the sternal border. Get as much medial dissection, that means as close to the sternum as possible, because that's what's going to give you that cleavage by getting that dissection in.
Everyone wants some cleavage.
Everyone wants cleavage. There are some patients, again, with a wide sternum where it's really difficult, and if you start going past that limit, you're going to start getting some complications you don't want. So your body does limit you a little bit in terms of how much cleavage you can get, but in general, you lift that muscle up, you do your dissection, and then this is where it gets really fun, right? So this is where you can start sort of, I call playing with your sizers, playing with your implants. Implants come with sizers in the operating room, and a sizer is sort of just a cheap version of an implant. It's not designed to be a permanent device, but you can put these sizers in during the operation. you close the patient up temporarily, you sit them up vertically in the OR. So your patients are still asleep, but you take them from lying down, you put them up, and then you look at the sizes and you see, how does that look? Does that approximate what the patient wanted? Does it look good? Does it need to go smaller, bigger? And then you start swapping out your sizes, bigger, smaller, until you find the size that matches what looks great on the patient and what she wanted.
Yeah, I mean, it's important to have those sizers because, a lot of times you think, this patient will look great with a, 375 cc high profile gel. When you put that in, you're like, I better do a 475. Because it just gets gobbled up into the chest wall, and especially you don't know how much there's space in between the ribs that can take up a lot of the volume. Yes. So every patient's different. So even though you may think this is what it's going to be based on base width and what they want and how much breast tissue there is, sometimes you get a real big surprise and you need those sizers. Otherwise you're, if you were to just say, okay, we're putting in this, size implant, you wouldn't get the best result every time.
You wouldn't. So that's where you try on different sizes, literally like trying on, different shirts or different pant sizes. You try on different sizes to find the right one that fits. And then you take that old sizer out, and that's when you do all of your antibiotic irrigations, your betadine irrigations. You wash that wound, that pocket really well to get any kind of remnant of bacteria out of there. And then you insert your breast implant and
the permanent one,
and then you close up your incision. And that, in a nutshell, is a breast implant surgery. And I think going back to the sizers, it's a really good point because that's always usually the number one question. Well, what size implant are you going to put in? And so how do you decide?
Beats me. I tell them, but I base it usually on what they want to achieve. They say, I'd like to be like maybe a C or a D. And I was like, well, it depends where you buy your bras. Do you have a picture of what you're talking about? They show me a picture. Then I say, okay, yeah, that's like a C or D. I get it. Then I go by the base width of their breast, and then I decide if they have enough breast tissue that they either need a moderate plus or a high profile gel. I rarely use the super high profiles because they look like torpedoes. I don't know, they're just not for me. But I like the high profile gels in general. Sometimes use the moderate plus. But it comes down to a narrow range of devices. I'm typically within 100 cc's. And typically the larger end of what I tell my team to have in the operating room, even though we have a wall of silicone back there. We have everything we have every single implant you can imagine up to a certain size. Like I don't have 800s back there laying around. If somebody wants the largest implant available, then I have to special order that. But for most patients, we have the implants available, so we just go with the sizers. And we sit them up, and sometimes you have to sit them up a lot of times. They actually get some abs from doing during the case, but it's fine. I mean, you want to get it right, so you go with the sizers. You look at how it looks, and once you get what you like, you close them up, and
there it is.
Bob's your uncle.
And I love the photos because patients will come in and say, I want to be a 32C. And then you say, oh, great, show me a photo of implants you like, of a size you like. And they show you a picture, and it's someone who's clearly like a double D. And you're like, okay, well, that's fine, but that's not a C. So I'm glad you told me that because now I know how to tailor the implant choice for you. And again, bra sizes are so subjective. Somebody who's a C cup in Victoria's Secret is probably a B cup at Nordstrom, and it's very subjective. But photos are great. They're super helpful because then it gives me an idea of exactly what it is that you're looking for.
Sometimes you do get some interesting photos.
You're like, oh, okay. All right, I see you.
Where did you find this? Exactly.
And I do say, if you can distinguish, bring photos of a woman that has implants in. That's way more helpful to me than bringing in someone that has naturally large breasts, because it's not an apples to apples comparison at all. And you really can't go by numbers, because like you said, some patients you put an implant in and their body sort of just swallows it up. So they might have come to you and said, well, my friend has 350 cc implants and I love the size she is. I want 350 cc implants. It's like, it doesn't work that way because every person has different amounts of their own breast tissue. They may have very little, they may have a lot, and 350 cc implants, someone that is already a C or D cup, is going to make them substantially bigger than 350 cc's in someone that might have been an A cup to start out with.
Yeah, it's, if you're 5'1" and you get 450s, well, that's very different than the woman who is 6'2" and gets 450 cc gel implants. The 5'1" gal will look like she has some large breasts, whereas the 6'2" woman will look like looks nice. It just the number is not the way to think about breast augmentation. This is an artistic procedure. The device is a tool, and it's all about preoperative diagnosis and planning to get the result that you want to get in the end.
I couldn't agree more.
It's another agreement. We are keeping score over here, so I'm gonna put that one up. So, what are the complications? What problems can you have with breast augmentation?
There are definitely problems that you can have in the immediate period right after surgery, which fortunately are pretty rare. Probably the two things I worry the most about would be bleeding, because that's a complication of any surgery.
Of course.
Bleeding after breast implants is a little bit more of a surgical emergency, not because you're losing blood and you're going to have an emergency because you're hemorrhaging blood out of your system, but because anytime blood, even a small amount, collects around an implant, it's a medium for infection. So if I can tell that you've bled a decent amount around your implant, I'm probably going to take you back to the operating room, wash out the old blood, put in a new implant, just to make sure we're back to like a safe, clean environment again. And that, fortunately, is pretty rare.
It is.
It's pretty rare. In the immediate time period, I always super paranoid about infection. Thankfully, in a cosmetic situation, a controlled environment, infection is also fairly rare for these patients. I see it more in my reconstruction patients. And if you were to have a complication like an infection, typically it would show up anywhere between 10 to 14 days, something like that, after surgery. Sometimes you can treat it with antibiotics, but if it's really the implant itself that's infected and making you sick, then you have to remove the implants. Fortunately, that's very rare.
Knock on wood, I've never had a breast implant infection in a primary breast augmentation. Breast reconstruction, different animal.
Yes, totally different.
Yeah, there's radiation, chemotherapy, all kinds of other things that cause, but those also very rare. But in primary breast augmentation, just knock on wood, haven't happened.
Usually been pretty good.
I think the biggest issue that patients really do experience is capsular contracture.
Capsular contracture. So then you're getting into the longer term complications of implants, and these are complications that occur at the earliest 3 months, but up to 3 years, 10 years afterwards. And the main one is capsular contracture. Capsular contracture is when anytime you put a foreign body into the patient, if any kind, anywhere, the body's reaction is to form a capsule around it. It's the body's way of sort of walling that foreign body off from the rest of the body. Usually that capsule is very thin and filmy, but in some patients, for reasons not well known, that capsule becomes thick. And it can be visually disturbing and it can be painful.
Yes.
So that's a whole different ballgame, but typically when it gets to that stage, you do have to go back and reoperate.
And that is measured on the Baker.
The Baker.
Scale. The Baker 1 is a normal capsule, Baker 2 having some firmness to it, Baker 3 being
it looks weird.
Visually disturbing, and Baker 4 being visually disturbing and painful.
And it hurts.
And so the Baker 3s and 4s, I think you wind up reoperating in general.
Yep.
There is a medication that you can use to treat it, and it works pretty well. Either Accolade or Singulair, both are effective in treating capsular contraction. Early.
Mild capsular contraction. It will hopefully stop it from getting worse or keep it at its mild stage. But once you've gone on to a Baker 3 or 4,
it's kind of over.
Yeah.
What is this?
Go ahead.
No, you go.
Well, I was going to say, I think it's too big a topic to delve into on this particular podcast, but at some point we will talk about the long-term complications such as breast implant illness and or ALCL, which are two totally different things, but that's a whole different involved discussion.
For sure, and also the treatment of capsular contraction.
And the treatment of capsular
Now again, we've covered these in other podcasts, but in our video format here, which I'm very excited about, we'll get into it a more visual approach.
Right.
What does it cost to have breast augmentation?
Primary breast augmentation, no lift, just putting in an implant.
$1 million. No.
$1 million. Yeah. My practice, I'm pretty standard, about $8,500 here in Beverly Hills, I think is my go-to cost. I know you're more.
That's a great deal. I would encourage everybody to see Dr. Revello, because for me, it's a lot more.
It's a lot more, yeah.
Yeah, I mean, it just depends on where you are in the country, who's doing it. The Beverly Hills prices are way higher.
Okay.
I think you can get a breast augmentation in parts of this country for $6,000 or $7,000.
Parts of LA, which is kind of scary to me because I know what the costs of operating in this city are, and they're not cheap. Because when you're buying an implant surgery, you're buying an actual implant, and that's a fixed cost.
Yeah, it's between $1,500 and $2,300
flat. There's not really a negotiating thing that's
right.
set
That's
by
what it costs to
implant
get the
company.
implant. That's right.
And then you're talking about time in the OR, so that's the OR facility fee plus the anesthesiologist.
If there is one.
Which I would
there are a lot of places
strongly encourage you to have an anesthesiologist in your room. If not,
come on,
have
people.
Second thoughts about who's doing your surgery. But those are fixed costs, and by the time you've added up all of those, it's easily $5,000, easily, if not more. So if you are in the city of LA or urban center and someone's offering you a breast aug for less than $6,000, I would be very hesitant about what's happening.
In our resident and fellows clinic, I think it's $6,500.
Right, because you're not charging a surgeon fee.
Yeah, they're not getting a surgeon fee. It's just straight cost for the residents and the fellows to do it.
That's the cheapest you can get, straight cost, OR anesthesia, implants, $6,500.
And that may be actually right on the penny, the cost of doing it, if I'm correct. Yeah, but it depends where you are in the country, because like getting operating room time in Los Angeles and Beverly Hills and Newport Beach and San Francisco is a whole different animal than getting OR time in Wichita, Kansas. It just is a very different cost structure. It's not better or worse. Some of the I think the surgeons in Wichita, Kansas are board certified and excellent at doing this, and you're going to pay a lot less if you go there.
Yeah.
If you come here, then you're going to get a different approach, and there's a different look. And yeah, I mean, breast augmentation is a little more expensive here. That's the way it is.
Welcome to California.
Yeah, that's part of the deal.
Yes.
It is. It is
not cheap.
Crazy insane to be here.
No.
What are we doing here?
I don't know.
If we just packed it up and moved to Vegas, our cost structure would be totally different.
So much cheaper and keep way more of my paycheck.
Totally different. That's true. Yeah, because you got to give 13% to the state of California.
Anyways.
13+%. It's awful. Okay, that's enough about that. We're not going to complain.
We're not. No one feels sorry for us.
Actually. Nobody feels sorry for the plastic surgeon. We get that. I'm all about it. So can you walk me through a case? I think you prepared something for me to look at.
I have a case. So I'm going to show you a pre-op of a patient that came to see me.
Okay.
Doctor?
And I'm going to tell you what I see, since most people are listening to this podcast as of right now.
So this is a young woman, 27 years old. She came to me. She says she's about a 34A, B cup at most breast size, and she wanted to be like a full D breast size. She'd had one child. She didn't really breastfeed very much. Otherwise healthy.
Yeah, and this is actually a difficult breast augmentation, and I'll tell you why. So what I see, first of all, there's breast asymmetry. Number one, the right nipple appears to be a bit lower than the left, although I'm looking at the shoulders and has a little bit cant to her, but at the same time it's still lower. The inframammary fold's lower. The left breast is larger than the right in two respects. There's more volume on the left one, less volume on the right, but also the presentation in terms of the directionality of the left chest wall is more flat and front facing, whereas the right chest wall, kind of like the keel of a ship, goes back into her. So this is by the way, every patient has chest wall asymmetry. And so when you were talking about you have to be 22 years old to get silicone gel implants, one of the exceptions is if you have chest wall asymmetry.
Yeah.
Well, everybody has chest wall asymmetry. There's nobody who has a symmetric chest.
True.
So we've covered that one. But I think this is a hard one, and I would definitely look at the base width, which I don't know what it is in her.
She was like 13 or something. But interesting enough, even though she had breastfed and she had been pregnant, she didn't have a lot of skin laxity, and her nipple to IMF distance is actually fairly short. So the distance from the nipple to the base of the implant, or to the fold, was like 4.5, and there wasn't a whole lot of stretch to it. And she wanted to be fairly large.
So with that said, then she has one other thing that's really not good for breast augmentation. She has the armpit things.
Yeah, I know. I know.
Those things are really tough.
Those are
What I'm talking
hard.
about is like in her armpits, there is like a skin fat bag that's hanging over that just really wrecks your breast augmentation unless you blow it out with a decent size implant.
Right, so I call them superior axillary rolls.
That's a nice name.
It's a nice name.
I call them armpit
things. And they do get better with an implant because you sort of camouflage that discrepancy from the fullness up there to the smaller size of the breast.
Right.
Some patients, if they're really extreme, I will offer liposuction to them at the same time. A lot of times I just say, hey, just so you know, this is still going to be there. We can always come back and do a little small lipo afterwards if you want. And it's up to them whatever they choose to do with it.
Well, I would go with some decent size implant, high profile gel, inframammary approach. I don't think I would try to address the nipple asymmetry because it's going to put a periareolar scar that's pretty significant and probably not necessary. I always tell patients the breasts are sisters, they're not twins, so they need to be. Now, if afterwards that there's enough asymmetry in the nipple areolar complexes, you can always give some local anesthesia and hike it up a little bit. Yeah, do a small lift. So yeah, that's how I would approach it. And what did you do?
So, we did talk about these asymmetries, and I said, just so you know, you're going to notice them afterwards. And she was fine with that. I wasn't going to go chasing it and do any kind of lifts or anything like that. The one thing I did do in her is I lowered her fold a little bit, just so that it wouldn't. So lowering the fold means putting the incision a little bit lower than the natural fold, just to give me more room to get a bigger implant in there. I felt like if I just did it right where her fold was, she'd be really top heavy and she wouldn't have as much fullness, below the nipple areolar complex. So that's what I did. We did a subpectoral. I used Sientras in her. Sientra 415 high profile implants.
Are they sponsoring this podcast? Because they should with that shout out right
I know. Although we also shouted out Allergan, so we will take any and all sponsors. We're not particularly discriminatory.
Not right now, unless somebody wants to be exclusive.
Unless you want us to be.
There is a price, and we're willing to accept it. Now, so is this the result?
This is your after, yes.
Oh, let's see. Boom! There you go. Much better. And you really took care of the asymmetry. So if you look, what I see is that, and I'll put that up for the viewing audience, but really what's happened is you've gotten great symmetry from the, and again, they're not going to be exactly the same. No. Sisters not, and they do look like sisters. No redheaded stepchildren here. Not that there's anything against them. But you've really addressed the size discrepancy, the nipple areolar complexes look like they belong together.
Right.
They're a little different.
One's still a little bit lower.
Totally okay.
Yeah.
Not worth a scar.
Nope.
Not even close. And the axillary fins look better.
They look better, and I didn't even really do anything to them.
No, and when you try to do things to them,
that's
you get problems.
That's weird, yeah.
Yeah, and everybody's like, can you just suck this out? Can't you? I'm like, no. We will leave them alone and act like they're not there.
Yeah.
And because the thing that you actually have to do to get rid of them is cut in the armpit.
I know.
That's what you have to do.
Yeah.
There's no way to suck that out or do some kind of treatment. They suck. They're the worst.
Especially if it's just skin. You got to find a way to remove the skin.
Well, that's awesome. Great job. Great case.
She's very happy.
Is that before and after available on your website?
Soon.
Not there yet. RevelloPlasticSurgery.com. Coming to you soon.
We were just talking about this. I have pages and albums of photos. I just, it's hard. Editing photos and getting them up there is time consuming. It's like a second job.
No, we don't have time to do it. We're busy operating. That's the hard thing. Well, great job.
Thank you, doctor.
For $8,500, sign me up. I'm in. Yes, mine is not double that, but it's close to double that in terms of price.
Close.
Yeah, double. But it's just I don't know. I guess I've been here too long, and I love doing breast augmentations, but it's more expensive for me to do it.
It's that gray hair fee.
I got a really big team. We need some really nice things.
That's
There's
the
your
gray
book.
hair fee.
Yeah, I just quoted, come on, it's
I
Drake.
know, I know.
Hello. No, the gray hair fee is definitely there. But it's also the experience fee. I think I make some really nice breasts.
That's the gray hair fee.
Bottom line,
Yeah,
you know?
that's the experience.
All right, well, anyway, thanks for having this discussion. Really appreciate it. Thanks to all of our listeners who have now forced us to go to video, which is great. I'm happy to do that. I think we'll get a lot more out of it. But this is the Beverly Hills Plastic Surgery Podcast, coming to you from the 90210.